ऑर्डर ऑर्डर ऑर्डर। कोर्ट की प्रोसीडिंग्स शुरू हो रही है और अब आप देखिए यहां पर दो अक्यूज्ड आपके सामने, दोनों ऑनरेबल अक्यूज्ड हैं। मैं यहां इनवाइट करता हूं डॉक्टर जतिन कोठारी को कि वो दोनों अक्यूज को सही जजमेंट देवें।
I think, sir, our case is going to be slightly different. Umesh, please give a big hand to Umesh. He's conducted a fantastic case, but I am a little bit of a cricket fan, so we are not going to let the judges sit quietly and observe the tamasha. We are going to have the system of if somebody gives a no ball, then I am going to invite the judges to come in and stop the person who is speaking, especially if he talks something aside other than evidence-based medicine. So no ball introduce कर रहा हूं मैं। एक DRS सिस्टम भी होगा जो जहां में आपको सबको पार्टिसिपेट करना है, जहां पे अपन एक पोल लेंगे कि ये जो हमारे दो अक्यूज्ड हैं आज कैसे प्रेजेंट करते हैं, और आप सबको भी मौका मिलेगा ताकि आप सब जागे रहें ये डिबेट के टाइम। सो मिलॉर्ड, विथ योर परमिशन आई विल कॉल द टू को-अक्यूज्ड। सबसे पहले पेंगुइन सिटी मुंबई से डॉक्टर विशु देशपांडे। उनकी पर्सनालिटी को देख के पेंगुइन नहीं लग रहे हैं, वो शेर लग रहे हैं, और अगले 20 मिनट में वो शेर बनेंगे या पेंगुइन बनेंगे वो हम देखेंगे। दूसरी ओर मेरे खास दोस्त मनोज गुंबर साहब, जिनको आप 5 किलोमीटर दूर से भी पहचान सकते हैं। ही इज फ्रॉम द वंडरफुल स्टेट ऑफ गुजरात एंड आई एम श्योर with the blessings of our Prime Minister, etc., he is always going to be a little bit more forceful. So, मेरी जजेस से यही दरख्वास्त है कि अगर गुंबर साहब बहुत अग्रेसिव हो जाएं, तो आप प्लीज उनको नो बॉल बताइएगा। The case today that we are going to discuss, friends, is about a disease called ankle vasculitis. And I couldn't agree more than our organizers that this is a topic which has seen a few good trials over the last 3 decades. Lot of evidence has emerged, and that's probably the reason, including this topic, I think is relevant to all of us, because everybody sitting here in the audience, my lord, must have seen cases of ankle vasculitis and dealt with the severe morbidity and mortality that these patients go through. So let's start with somebody who is going to propose that all patients with severe ankle vasculitis should undergo plasmapheresis. I need to inform all of you that all the existing evidence has been shared with both the speakers by myself, and Sachin had clearly told me that no slides, no PowerPoint is allowed, so none of them will be able to read anything. So we are going to rely on their memory, which I am sure both of them have wonderful memory. And if there is anything that you go a little bit haywire, I will again ask the judges to intervene and no ball you. Okay? So let's start with Manoj, who is going to propose that everybody who's got severe ankle vasculitis, I stress on the word severe because that's the most important part according to my analysis, severe ankle vasculitis, plasmapheresis should be done. Manoj.
First of all, I will be in favor of Plex because I have learned, I have taught, and I am still teaching Plex is in for ankle vasculitis. This all thing actually started with Plexiva's trial actually. Before that, everybody believed in Plex. But how can you rely on a trial where no renal biopsy was actually required to recruit the patients? And we know that sclerosed glomeruli and in patients of crescentic glomeruli, the presentation of GFR will be similar in both. So we do not know. हाला मरे हुए को मार रहे हैं या जिंदे को जीना कर रहा है वो पता ही नहीं है हमें. So I think renal biopsy must be there.
आप नो बॉल के करीब जा रहे हैं क्योंकि मैं
सेकंड पॉइंट
आपको बताना चाहूंगा कि एंकल वास्कुलाइटिस के आउटकम्स ये किडनी बायोप्सी पे कभी प्रूव नहीं हुए हैं. Whether biopsy helps you to improve outcomes, that has never been proven. But we will allow you to present your next point.
Sir, it was an open label trial, sir. And if believers in Plex like me will never enroll severe vasculitis patients and in patients of alveolar hemorrhage, we still American Society of Nephrology still says that it is category 1 indication, and still 27% of the patients were of alveolar hemorrhage. Sir,
गुड पॉइंट. ये आपको शायद फ्री हिट मिल सकता है मेरे हिसाब से, जो आपने अभी 2 पॉइंट बताए हैं, पर पहले हम आपके ओपोनेंट से सुनेंगे, उसके बाद उसका जजमेंट देंगे जज साहब. सो एनी अदर पॉइंट्स व्हिच यू वांट टू पुट फॉरवर्ड बिफोर आई इनवाइट ऋषि टू टेक ओवर and tell us what bad we can do to the patient with plex?
Again, think that plex was designed for severe ANCA vasculitis. Only 27% of patients had a creatinine of 5.7. 20% patients required hemodialysis on presentation. Only 14% which patients expired, and only 20% patients remained on. They went to ESRD at the end of observation period. Are we really dealing with severe ANCA vasculitis?
Valid points, Manoj, valid points. And what you are trying to emphasize and prove to everybody is that plexivas is not representative completely of severe ANCA vasculitis. So that point we would have to give to him, Jaj Sahab. But let's hear now with the might of Mumbai, Rishi Deshpande, who works in a private sector where money is not important to him. His patients can afford crores of rupees. They can do 500 plasmapheresis if required. We are not talking about that category of patients. We are talking about a routine patient in India who has challenged Ma card. Somebody mentioned Ma card in Gujarat, where plasmapheresis payment is so less that you probably cannot even do one plasmapheresis for a patient. So, Rishi, your points in favor of doing or against plasmapheresis.
Hi, good morning, everybody. So, I must thank the organizers, Jatin, and our judges for this opportunity.
Don't thank us all. You are not going to win on that basis. So please start your.
Jatin, that's just the confidence. What's the result? Anyway, see, the point is this. You asked my opponent a question and he answered defensively as to why it should not be done. Why that trial was not representative. He did not go in favor as to why plex should be done and how it is going to help his patients. That itself, I think, is the take-home message from this. When you are trying to sell a therapy and not quote why it is beneficial to your patients. I mean, you are believing in something, but all of us believed that more dialysis is better till hemo study came. All of us believe that statins.
No, let's stay with our case. Okay. We don't have time to discuss about all other nephrology trials. Please come to the point.
Sure. So basically, I'll tell you one thing. In a nutshell, state-of-the-art evidence clearly states that plex does not have a role in management of severe ANCA vasculitis with renal involvement. And as of today, you cannot make any definitive statement with the available evidence that plex should be given to the patient. If I was to look at from a patient's perspective, what are you trying to give me? A expensive treatment, a treatment with complications, and trying to tell me that there is no proven benefit of this, but we believe it will work for you. Why? Because the word ANCA, the antibody, yes, it is staying, it's an IgG antibody which stays.
We'll come to ANCA, that's a very valid point. But I get your point that you're trying to say that 700 patient study, is that not enough for you to prove whether a particular treatment should be beneficial in a multicentric trial of 700 patients across continents? That should be good enough to prove your point, right? Is that what you are saying?
The Plexiva study was designed on the basis of the older RCTs and observational trials, which showed that a statistical difference of 25% in favor of plex can be proven if you enroll 500 odd patients. They have enrolled 700 plus patients, 16 countries, representative of a global sample, and failed to prove that it is showing a benefit.
Yeah. Great. Manoj, let's come back to and go a little time.
I'll interrupt you. Rishi.
Sir, you are no balling him. We will have to signal no ball.
No. Why should I say? I'm as judge. I'm allowed to interrupt at any time.
Yes, sir. Of course. That you don't need even when you are not a judge. Yes, sir.
Rishi, first thing I have taught you is we agree to disagree.
Yes.
So you define which case of ANCA vasculitis deserves plasmapheresis.
Yes, sir. So we will come to that. That's my point where we are going to say that it's a free hit, where essentially that has to be done, and we are going to have that discussed in our How are we doing on time, Sachin? We are okay? About 10 minutes. Oh, great. Okay, so Manoj, let's go back to the trial that you were telling us about, MEPEX trial 2003. Very strong evidence that plasmapheresis helps in severe ANCA vasculitis. Your observations, evidence-based medicine. I learned a new term called evidence-informed medicine from Vivek Jha a few weeks back. So whether it's evidence-based medicine, evidence-informed medicine, please tell us about MEPEX and why you are a proponent of PLEX in severe ANCA vasculitis.
Sir, MEPEX trial, 137 patients. All patients more than 5.7 milligram percentage creatinine. 51% patient actually died in both groups. Then all patients were biopsied. 56% had cellular crescents. The outcome measured at 3 months and 12 months and not 2.9 years. It was renal outcome was the primary outcome and not taking ESRD and death as one as in Pexivas trial. At 3 months and 12 months, even if you look at the Pexivas trial, there is a benefit. The only thing is, average age of the countries which their trials were conducted is 63 years. While if you go through that Indian data, average age is 40 years. Will you not preserve the renal function at 3 months and 12 months and increase the longevity of the life of the patient and also the kidney? Look at the comorbidities which you have at 63 years. Look at the incidence of infections which you have. MEPEX was given 2.5 milligram of cyclophosphamide, high dose regimen. Now you have low dose regimen in Pexivas trial, which shows that you can use it without increasing the incidence of relapse.
So there I will stop you because we don't want to discuss whether other immunosuppressive strategies, which one is better. We're not talking about steroids, we're not talking about other drugs. Stick to plasmapheresis itself. Yes. Please go ahead.
So MEPEX is more likely to the patients of Indian patients. They present late. Average creatinine of presentation of Indian is 4.6, while Pexivas was 3.2.
Point well taken. Rishi, I will come over to you now because these are very pertinent points which are India specific, and as in the previous debate, we heard that we do have to change our policy based on our local dynamics, cost factor. Most of the trials that both of you are quoting essentially never look at cost. These are done in developed countries where the cost is never an issue. Obviously, it's not an issue in a trial anyways, but in practice, how would you use that evidence from MEPEX to even say that you should not use plasmapheresis as a blind treatment for all people who have severe ANCA vasculitis?
You look at MEPEX 4 years down the line, I'm sure Dr. Manoj knows this. The same patients that were followed with plasma treatment and without the PLEX, there was no difference in renal survival or mortality at the end of 4 years in a follow-up of the MEPEX trial.
Good point. So we are talking about long-term outcomes here. But again, severe ANCA vasculitis, his point was that we are looking at relatively short-term mortality and benefit also, which is also important.
Short-term mortality he has already quoted as similar in both the groups. So whether by doing plasma you have not improved mortality. When long-term renal function maintenance, what was his point for MEPEX? Even that is taken away by the follow-up of the MEPEX at the end of 4 years, which is telling you that you are not improving renal survival at the end of 4 years. And also, I'm very happy that he is quoting Pexivas trial. So it is super selective memory is what I would quote for my opponent, where you say, I like some part of this trial, so I'm going to say that this is correct. But some part of the trial which doesn't suit my purpose is not correct. This is like Karna from Mahabharata. You are fighting on the wrong side, but you want to do the defense. I can't help.
Yes.
Sir, Amitabh Bachchan will remain Amitabh Bachchan, and then we look at Ranveer Singh, what he has to do, sir.
Judge Saab, I think these points have been well covered. Just one aspect regarding ANCA, because that was something which Manoj brought out. In terms of ANCA being pathogenic, we talk about ANCA vasculitis and we ourselves don't know whether ANCA is a big factor. So if you permit 2 minutes, we can allow both of them to talk about ANCA and its relationship to actual pathogenicity, whether we have significant data by itself. Because the whole context of ANCA vasculitis becomes irrelevant if you don't know what actually ANCA is doing. So maybe Manoj, you can start and then we will allow Rishi to talk about that.
Sir, we are developing therapies now based on ANCA. We have C5a inhibitors in this study. We believe that C5a receptor will be the in thing in the next thing. We believe that rituximab acts and is effective in ANCA-associated vasculitis. If rituximab is effective in ANCA-associated vasculitis, definitely ANCAs have a role. ANCAs definitely get reduced by plasmapheresis very easily. Even in one session, almost like 60% of the reduction is there in, I'm sorry, not 60%, but 80% reduction in 5 sessions.
Okay,
45
let me
into-
come to your point. I get your point, Manoj, but so are you saying that you monitor ANCA in a patient who's got ANCA vasculitis, and does that correlate with outcomes in your personal experience? Because at least data doesn't seem to support that. I'm sure Rishi is going to be back with his counter, but your point on that, do you monitor ANCA?
I do not monitor ANCA.
So in a way, you are saying that ANCA is important, but I don't have the resources to do ANCA. Is that the reason?
No, but there are trials which have been on titers, and to prevent relapse, even before the relapse occurs, they have done the plasmapheresis so that relapse does not occur.
Fair point, Rishi.
So I would like to state 2 points, Jatin. First, we believe ANCA is pathogenic. However, KDIGO is on record to say that if ANCA recurs after your treatment is over, no problem. If the creatinine is fine, don't change the treatment. If the ANCA titer is rising but your patient is fine, don't worry, no need to change the treatment. But we all believe ANCA is pathogenic. That's
Correct.
point number
And
one. And
if I was to add one point, Jatsa, is that essentially, except for animal data, there has never been a human experiment which has been done to show that ANCA is pathogenic per se. So that point, I think we would score it on to you, saying that yes, there is no clear role of pathogenicity. It's something probably that still is in evolution.
the second thing I would like
Yes.
to say on the same ANCA point is that maybe you are trying to douse the fire too late, because your ANCA, even if I agree that it is pathogenic, the damage is already done, and now trying to remove the ANCA is not giving you the benefits you desired, and that's why your plex is not working, but your other immunosuppression is working.
Fair point. Yes, sir. Yes, sir.
I would like, this debate is a very important debate. Let's take the comedy out of it and go to the tragedy. Okay.
Sure.
I want both, in their 2 minutes left, to define when and where plasmapheresis is indicated in a case of ANCA.
Great, sir.
And
So I think we should start with Rishi.
Is it their contention that every case should get or no case should get?
Yes.
Because this is serious. A lot of people in the audience may not have read these trials. Therefore, we must go home with a take-home message.
Yes.
And after this, I'm going to put it to the jury. I'm going to show by vote of hands what they thought. So
Sure.
come on.
So Rishi, let's start with you.
Let's start with
Despite being on the con side of the debate, please tell us which are the indications where you...
Side, no?
No, Manoj is going to say that he is going to do plasmapheresis for everybody. So let's start with Rishi.
No, let him say. No.
Okay,
why
let's go
put words
ahead. Yeah,
in his
Manoj.
mouth?
I'll to go for a case-to-case basis. Severe ANCA vasculitis
Tell
requiring
me
dialysis
the absolute indications where you would do plasmapheresis in your ANCA vasculitis patient.
with alveolar hemorrhage.
Alveolar hemorrhage, so diffuse alveolar hemorrhage, everybody agrees? Great.
ANCA with GBM.
ANCA with GBM, no questions asked. GBM should be getting plasmapheresis anyways. Point 2.
Or
3.
all cellular crescents. Active.
So that's the
acute
dilemma.
kidney
That's the
involvement
dilemma whether you have the biopsy evidence to
without
prove it.
hemorrhage.
Okay. And there is probably one more, Rishi, any points to add?
See, the only thing I would agree with here, without any debate, is the overlap syndrome. The ANCA with anti-GBM disease deserves plasma exchange. The other two contentions, severe renal disease, that is what the Pexiva study was all about. And the biggest...
Unfortunately, no, I'm sorry to disagree with that. You had only 29% people, only 1/3 of people who require dialysis. Diffuse alveolar hemorrhage was only a small segment. So there I would, sir, agree with your permission that diffuse alveolar hemorrhage has to be a clear-cut indication where you would have to do plasmapheresis.
Even that subset of patients that have been analyzed in that study is bigger than the MEPEX cohort.
I agree. The numbers game, if you look at it that way, that is right. But still a significant number of patients benefited when they had diffuse alveolar hemorrhage. Any other points? There is one more point which I want to stress before we have the judges mention their verdict.
I mean, the
Young patients. What about young patients?
The age,
Indian young patient,
Yes.
40 years. Why will you not take the opportunity for early survival of renal failure?
Correct. So the tolerability of plasmapheresis is in question here. The tolerability of plasmapheresis, and within the resource limited setting, if you can offer them a few plasmapheresis, they will definitely benefit as far as the young population goes, sir.
I think
Yes.
what
There
you
is
are
a
saying,
meta
even,
analysis
Yes,
done
Manoj.
in BMJ.
Yes.
Published.
I think not just the opponent, but even the prosecutor, if I say that, I personally think that if we just look at the current evidence, all that you have added is practice based and not really evidence based. I do agree that we all feel that yes, doing Plex is the right thing for these indications, younger patients, cellular crescents, rapidly progressive glomerulonephritis. However, the data does not seem to support us.
Okay,
Sir,
I will leave
yeah,
the final decision to the judges, and of course we can have our audience poll and show of hands, sir.
Yeah.
Thank you.
Okay, both
Peter
of
also
these.
has.
Yeah, I have just one thing. That both of them have not covered much about the over immunosuppression. So what do you
Sir, that could be another debate. That's why we wanted to keep it out in terms of the interest of time. So that's the reason why Sachin had told me that we should not discuss other immunosuppressive strategies. But maybe you can make a point on that. Yes.
No, my point is exactly what Dr. Salga says, that why is it, Rishi, that you don't want to give this therapy to everybody? What are the downsides? That's very
So the
important.
exactly. The downsides are I am going to sell a therapy to a person which is non-evidence based, which is expensive, which has a lot of infection potential, procedures involved, bleeding, risk of infections, and without a proven benefit.
No increase in infection in the both groups. In all trials.
We know where it was done.
No, it was not. No evidence of increased infection in both groups.
Is that correct?
Yes.
Only for the Pexivas data, yes, it is correct.
MEPEX trial also.
All right. So I think we've had both sides, and I think that we go to the jury and see. We'll define, and you define the point. I'll ask the prosecutor to ask the jury at what point you present a case and say, will you give this person plasmapheresis? Don't, without his answering, giving you the data, don't answer.
So 35-year-old female in Mumbai having creatinine of 6.5 at presentation, required dialysis, X-ray shows diffuse interstitial shadows, bronchial lavage confirms alveolar hemorrhage. I want to hear from all the participating or all the audience, will you give plasmapheresis to this patient? Okay, so that is the judgment that we have got.
No, but I have something to say. I'm forwarding it to the Supreme Court. God will look after the patient.
Sorry,
Thank you for everything.
Thank you.
Even
Sir.
in Twitter, sir, 63% still believe after the Pexivas trial, even after Pexivas trial, 63% clinicians still believe they will go for plasmapheresis. Yes, and obviously,
We just saw
it
it.
is the
Thank you,
evidence.
So we know that 63% do believe.
Thank you, everybody.
Thank you.
We should move.
And